Welcome, and thank you for viewing this program. This module discusses the potential risks and side effects of radical prostatectomy. Radical prostatectomy involves the complete surgical removal of the prostate, along with its surrounding structures. It is indicated for localized tumors confined to the prostate in an attempt to cure the cancer, and for advanced tumors with spread beyond the prostate to control cancer growth and improve survival time. This is often in combination with other treatments. This slide shows how the prostate, the seminal vesicles, and the ejaculatory ducts are removed, and the neck of the bladder is then sewn back to the cut end of the urine channel or urethra. Risks of prostatectomy can be broken down into those that can occur during surgery, those that can occur shortly after, and those that can occur or persist long after surgery. For most patients, radical prostatectomy is a straightforward and safe procedure. However, it is considered major surgery, and complications do occasionally occur. Overall, there is a very small risk of death during prostatectomy of less than 1%. Causes of death may include such things as excessive bleeding, heart attack, heart failure, or stroke, blood clots to the lungs, and pneumonia or other infections. During surgery, significant bleeding is not common, with the average blood loss these days being certainly less than 1,000 milliliters. Overall, blood transfusion may be required in up to 5 to 10% of cases. Nerve sparing may slightly increase the average blood loss. Injury to the rectum, as the prostate is separated away from it, occurs in less than 1% of cases. There may be increased risk in certain situations, such as with prior radiation, prostate surgery such as TURP or TURP, or rectal surgery. When it does occur, this problem is usually fixed at the time of surgery with no subsequent consequences. Very, very rarely, it may require colostomy or lead to a fistula with drainage of bowel contents through the urinary tract. Injury to the ureters, the tubes that drain urine from the kidneys, occurs in less than 0.5% of cases, and is probably more likely with advanced tumors or very large prostates. Injury to a nerve called the obturator nerve may very rarely occur during lymph node dissection. This may result in some weakness of thigh movement, causing difficulty getting in or out of a bed or car. If it is actually cut, it should be fixed at the time of surgery. If, however, it is just bruised, stretched, or suffers some heat damage from electrocautery, it should recover slowly over several weeks, and may require some physical therapy. Even despite a great amount of caution taken in the operating room, problems can rarely result from the way a person is positioned on the operating table, or the way that retracting devices are placed. Nerves such as those in the arm or leg can be stretched or damaged by positioning, and a particular nerve in the leg called the femoral nerve can be compressed by retractors. Treatment for these situations is physical therapy, or very rarely surgery. These conditions may take many weeks to resolve. Back soreness or stiffness may also be felt after surgery from lying on the stiff operating table. Modern anesthesia has become very safe, and this will be discussed in detail between you and the anesthesiologist. Lung and heart complications, etc., can rarely result from general anesthesia, and severe headache is a rare complication of spinal anesthesia. There are other complications that may occur in the first few days after surgery. Heart problems such as heart attack, heart failure, or rhythm changes are uncommon after prostatectomy, but do occur on occasion. Specifically, the risk of heart attack is about 0 to 0.5%. Lung problems may also rarely occur. The lungs do often become partly collapsed after a general anesthetic, and this is called atelectasis. For this reason, you will be encouraged to do breathing exercises after surgery. Pneumonia is an uncommon complication of prostatectomy. Ongoing or delayed bleeding is a rare complication, and may require a return to the operating room. Infections of the bladder, wound, abdomen, bowels, or intravenous line sites may occur in 1% of cases. Prolonged drainage of urine from the drain tube may occur in 1 to 10% of radical prostatectomies. This is usually caused by a persistent opening at the site of connection between the bladder and urethra that allows urine to drain out through it. This problem usually resolves in time, and only very rarely requires reoperation. It may, however, require that the drain tube and/or catheter stay in for a longer period of time. In some rare cases, the catheter may stay in for up to 2 to 3 months. Slow return of bowel function, called an ileus, occasionally occurs after prostatectomy, and this may prolong the hospital stay slightly until normal function recovers. Finally, swelling of the genitals or lower limbs may occur from temporary obstruction of lymph drainage. Catheter problems can be disturbing early after surgery, particularly when the catheter unexpectedly falls out or gets pulled out too early. If this occurs in the first few days, it usually requires that a urologist replace it using the assistance of a cystoscope or flexible telescope into the bladder. Importantly, blood clot in the legs, called deep venous thrombosis or DVT, or in the lungs, called pulmonary embolus or PE, may occur from poor venous circulation during and after surgery while the patient is immobile. This potentially fatal complication can occur with any operation, and measures are taken to prevent it, including the use of special compression devices on the legs, drugs to prevent clotting, and early mobilization. This problem may occur while in hospital, or rarely after discharge home. After radical prostatectomy, the risk of DVT is about 1 to 3%, and the risk of pulmonary embolus is 0.5 to 2%. If lymph node dissection has been performed, some lymph fluid may collect in the pelvis and form what is called a lymphocele. Significant lymphoceles occur in about 0.5 to 2% of cases and may require a drainage tube to be placed, or rarely surgery. Similarly, if urine leaks out around the anastomosis, it may also collect in the pelvis, forming a urinoma. This is treated in the same way. Finally, wound or incision problems are uncommon after prostatectomy, occurring in about 1% of cases. In the worst of these cases, the wound may totally break down, called a dehiscence, and require reoperation to close it again. Or it may partially open and allow protrusion of abdominal contents, called a hernia. Having said all this, the greatest concern for most men considering prostatectomy is of the potential long-term complications. There are 3 main risks to be aware of, as listed here: erectile dysfunction, or ED, loss of urinary control, or incontinence, and scarring at the bladder neck. The important subject of erectile dysfunction and its relationship to all prostate cancer treatments is discussed in detail in its own separate module. A few key points are reviewed here. The likelihood of erectile dysfunction after prostatectomy is difficult to predict for any individual, and depends on a number of different factors, especially age, the quality of erections before surgery, and nerve sparing. Reflecting this high degree of variability, the chances of ED after surgery are about 20 to 80%, with less than 10% of men reporting the same function after surgery as before. Some men have also reported that they notice a slight shortening of the length of the penis after surgery. With nerve sparing, erectile function will typically return 10 to 18 months after surgery, even earlier for some and even later for others. Some reports have even shown men experiencing return of function up to 4 years after surgery. Many good treatments are now available to assist with erections, and many doctors will recommend beginning treatment early while waiting for nerve function to recover. Use of oral medications or injections early after surgery may help speed the return of erections after surgery. However, differing opinions exist. This is discussed in more detail in a separate module. Making lifestyle changes, like stopping smoking, losing weight, eating well, and getting regular exercise, can also help to maximize erectile function. The topic of urinary control after prostate surgery is also discussed in its own module. Men have 2 levels of urinary control: a so-called internal urinary sphincter, or valve, and an external urinary sphincter. Prostatectomy removes the internal valve mechanism so that a man must rely on the external sphincter for control. Because radical prostatectomy can also weaken external sphincter function, loss of urinary control, called stress incontinence, can result. This drawing shows how the internal sphincter or valve mechanism is contained within the neck of the bladder and part of the urethra surrounded by the prostate. This valve is removed during prostatectomy, so urinary control becomes more dependent on the external sphincter or valve. The external sphincter is the muscle that we can voluntarily contract to stop our urine flow. Complicating matters, incontinence can also result from an overactive or spastic bladder, called urgency incontinence, or from obstruction of bladder emptying, called overflow incontinence. Overactive bladder in men is discussed in its own separate module. Regardless, when the catheter first comes out, leakage is common. Most men, however, recover good control very quickly. Full control may take up to 1 to 2 years to regain. As mentioned previously, it is thought that pelvic muscle or Kegel exercises may speed the recovery of urinary control. As with ED, numerous factors determine the likelihood of incontinence after radical prostatectomy, especially age and surgical technique. Overall, about 5 to 20% of men will use protective pads after surgery. 15 to 20% will have only small amounts of leakage, while 2 to 10% may have more significant leakage and may ultimately require surgical correction. When necessary, good treatments do exist if leakage does persist. The final late complication to mention here is that of scar tissue buildup at the bladder neck, called a bladder neck contracture, which occurs after 1 to 5% of radical prostatectomies. This may result in slowing of the urinary stream, difficulty emptying the bladder, or incontinence. It is usually treated with a simple outpatient procedure performed endoscopically, in other words with no external cuts, to cut or dilate the scar tissue. It may sometimes also require self-dilatation by the patient. This drawing shows how scar tissue forms after the prostate has been removed, where the bladder and urethra have been sewn back together. Once you have returned home from surgery, please call your surgeon or other healthcare provider if you develop any of the following or other significant concerns: fever, nausea and vomiting, uncontrollable pain, cough or shortness of breath, swelling and tenderness of the legs, chest pain, trouble with the catheter or difficulties passing urine once the catheter is out, or if the incision becomes red, tender, or swollen. In summary, radical prostatectomy involves the complete surgical removal of the prostate along with surrounding structures. It is performed with the goal of curing or at least helping to control prostate cancer. It is considered major surgery, and as such, several important risks need to be understood prior to undertaking the operation. These risks have been outlined in detail in this presentation. Overall, radical prostatectomy is a common and safe operation, and the satisfaction rate with surgery is high. Thank you again for viewing this educational program.